Yeah, back.
So should I make you, can we see you also?
Yes, now you can. I was doing some extremely important work.
That's fine. Know more about it.
So we are about 90 people online.
Okay. So what do
So
you
may I
say?
suggest a small opening statement? So
Sure.
guys, I think stroke is something which we all need to know in depth about. And fortunately, we have some very passionate people about stroke in our team. Dr. Raj Srinivas and Dr. Vipul Gupta. So these guys breathe stroke. So they want to, tell you about the interventional component of acute stroke, and we'll take it up from here. So what I'll do is uh, uh, Vipul, you can make me the host now.
All right, I will do that.
So I'll mute everybody else except Vipul and Raj. And if somebody has to ask any questions, then on the right side, there is a group chat option, which you can, put into, and we will take the questions at the end.
So just to add on, maybe we could have communicated better when we wrote about neurointervention stroke. It meant ischemic as well as hemorrhagic stroke. So, we'll be covering acute stroke and carotid intracranial stenosis, and also pretty well the aneurysms, AVMs, which we treat as part of hemorrhagic stroke. Okay. And I think personally, I feel in the current era, everybody treats everything. So ischemic stroke may end up with a neurosurgeon, and most of the hemorrhagic stroke actually initially seen by a neurologist. And of course, there are many interventional neurologists nowadays as well, as Raj is part of a team. So I think that is worthwhile that, we try, rather than having too many seminars, we'll try to cover it in one go. And as I said, if you think one topic has not been covered in detail, we are very open to, as long as you want to discuss, and we can answer questions afterwards.
I'm unmuting everybody.
All right.
Sorry, muting everybody. And I'm unmuting you and Dr. Raj. Is it okay?
Yeah.
Absolutely.
So whenever you're comfortable, Vipul, you can start. We're already 100 people online.
Yeah, I think we can start now. What do you guys say? What do you say, Raj? We start?
Yes, you should start.
Yeah, I think you should.
All right, great.
I'm switching my video and audio off.
Okay, guys. Good afternoon. I hope you enjoy this short session. So, as Dr. Smith had discussed, we are going to talk about neurointervention in ischemic and hemorrhagic stroke, and how actually I want to talk about the advances, what advanced things we are doing, and how we thought initially what was untreatable to us, and which is becoming, in a way, treatable. So, all right. Now coming to ischemic stroke first, which is to me is the hottest topic, although I don't think even now that as many cases we are doing as we should be doing. And I think all of us know the logic that when the stroke happens, there's a small core and big area of penumbra, which is still viable. And as the time passes by, this keeps increasing. And if we can do a recanalization early on, then we can stop this from expanding, and patient will have a better chance of recovery. And all of us have seen miraculous cases, patient hemiplegic improving right on table. So, everybody is now no longer argument is how to implement this program. Most of these cases in our department, we are still doing by the most reported technique, which is we take a microcatheter across the clot, we deploy a stent retriever, we inflate the balloon guiding, and we take out the clot. Although a lot of modification of these techniques have come in, something known as Solomra technique I will show. Sometimes we do even aspiration technique in our department, particularly in posterior circulation, in which you take a wide bore catheter and just suck out that clot. Talking about advances, these are the initial guidelines which came in 2015, in which you have to make it very short. I would say any patient who was previously well preserved has a major vessel occlusion. One of the main arteries of brain is occluded. has significant neurological deficit in terms of NHSS more than equal to 6, not a big infarction with aspects more than equal to 6, and treatment could be initiated within first 6 hours. These were the initial guidelines, and IVTPA could be given, but you should not be waiting for the IVTPA to work. So IVTPA was no issue. You give you IVTPA and continue with the procedure. These were the initial guidelines. And this is this is one of the first few cases which we had done when I was in Vedanta. This patient presented, he had a cardiac issues. You can see the clot, hyperdense ICA and the MCA. CT angio, so that what you want to have a very quick CT in these patients, and CT occlusion was there. Intracranial IC-MC occlusion is IC occlusion, IC and MC occlusion is there. And at that time we were doing perfusion imaging, and you can see this was the small core in the cerebral CBV images, and CBF images shows a large penumbra. And so we went ahead with the intervention, and this was the angiogram IC occlusion. We took out the clot using a stent retriever with complete recanalization. This is the CT scan done the next day, and this shows a little bit of dye. There is a lot of time we see dye score of infarct, which wasn't bleed, and patient made almost complete recovery, as it is very miraculous. And we publish our initial details about using CD perfusion for major vessel occlusion. But what about the evolution? Number one evolution, which is the biggest one, which is already part of these publications, is that now selected cases we can do up to 24 hours, and this has come through Dawn trial and Diffuse 3 trial. So the Dawn trial went up to 24 hours, in which they mainly had used Treatable, and what they found, that was a very, very major improvement when patient had a small infarct, smallish infarct, significant deficient, and they went ahead with thrombectomy. If you have to go into the guidelines, these were what they were doing. More than 80 years of age, when NHS is more than equal to 10, and core has to be very small, less than 20 cc. Less than 80 to 80 years, when NHS is more than 10, core has to be less than 30. When NHS is more than 20, core could be up to 50 cc or so. Although one of the catch or Dawn trial, most of the patients had small infarcts, but there were massive improvement, and they even did the evaluation in terms of 6 to 12 hours, 12 to 24 hours, and again the differences were maintained. So very robust study in those terms. Then came the Diffuse 3 study, which again showed when the ischemic core volume was less than 70 ml and mismatch ratio more than 1.8 and mismatch volume more than 15. Again, they saw very significant improvement in these patients. And this has become a part of the guideline. AHSA guidelines have published this now. So that means 6 to 16 hours also we can take up, and selected patient up to 24 hours. The evidence is 2A for that. And we can go ahead with mechanical thrombectomy, which is huge, because particularly in our country where patients come in late, this can really benefit a lot more patients than what we could do previously. Now, coming to another, another issue. This is what one of these cases, representative cases of what I'm talking about. 32-year-old lady had dry hemiplegia, but she belonged to a rural area. She came 11 hours after the onset, and this was the infarct. Now, the key thing here, what we can see, the infarct is not very big. The internal capsule is spared. The motor cortex was spared. So although this was very late, 11 hours later, but she had significant deficit, and one would go. Can everybody hear me?
Yes, sir.
Okay. So MCA was occluded, but there are good collaterals, which is always a good sign. And we could see MC occlusion, which was recanalized by aspiration in this case. And this was the post-op CT. The infarct volume remained stable, and she made almost a complete recovery. So again, time is not a limit. It is how much is the deficit? How much is the infarct? And that is the key in deciding that whether we go ahead or not. But another thing, when you know this is such a robust treatment method, what about patients with slightly largish infarct? I mean, what's the harm in opening up? So people have been trying to, we don't know the right answers at this point of time, but people have been trying to stretch the envelope here. So largish infarct, also some patients can benefit. Like this patient, he was 47-year-old male with left-sided weakness. You can see it's a largish infarct. And the MCA was occluded to do it or not at 6 hours, borderline again, and HSS was very high. Young man, right-sided, and so we decided that we would go ahead. So this was the MCA occlusion, the occlusion of the MCA here in the DSA, and we recanalized the artery completely. look at this scan, it doesn't look very pretty, right? But this patient started moving the same side, opposite side, same evening. So he'd benefit again. So some of these patients with largest infarct may benefit. It's not that always. As I mentioned, the key factors here are which side, right side patients may improve, up to aspects 5. It's not that every biggest infarct you treat will never going to move. Aspects of 5 or so. From 6 we have come to 5. When it comes 4 or lower, it doesn't really work out so well. When the critical areas are spared, the motor cortex completely involved, whatever you may do, it is not going to improve. So all these factors, whether this age, youngish age will benefit, right side, critical areas spared, and aspects of 5. Even then the prognosis is not as great as with smallest infarct, and you have to warn the patient accordingly. Now, another dilemma is, what about patients with major vessel occlusions and who don't have a major, I think all of you neurologists, neurosurgeons have seen such cases. Like this patient, 35-year-old female with left-sided symptoms, sorry, right-sided. One second, there's some issue with my, okay. So, this was the trouble here. You can see this is the classical IC origin, and then tapers off, and there is a loop here, and there's a severe blockage here. This is very typical of dissection. I mean, this can be a teaching slide for radiology as well. Whenever we see a picture, we know this is 100% dissection. So it is almost like a major vessel occlusion. Our patient is quite well preserved to do or not to do. Again, is a big dilemma. Some of these patients may deteriorate. So we treated this patient by anticoagulation as well as antiplatelet. But 12 hours later, she developed right side dense weakness, and repeat CT angiogram showed IC occlusion. So we went in, there were no good collaterals, no ACOM, no PCOM. No wonder when the IC got occluded, patient deteriorated. This is the angiogram. IC is completely occluded. So we went in, my colleague Dr. Rashnivas had done this procedure. You can see this is here. So first he did an aspiration here and sucked out the clot. Now you can see the dissected flaps, always has some pseudoaneurysm. And then he made multiple angles to see where the true lumen is. So this is very important dissection, that you have to go through the true lumen, and he crossed it, and this is the microcatheter, and he placed what you can see from one end to this end. This is a detachable stent, and when he was sure, he detached it and complete recanalization. So the moral of the story is that some of these patients with large vessel occlusion and who are well preserved, significant number of them may deteriorate in the next few hours or a day or so. So you have to be very, very vigilant upon them, number one. Number two is patient with IC dissection as a classical radiology imaging, which will always be able to diagnose this. And third part, I would say, is that when you're doing, I mean, most of the dissections you can manage medically, but some of them we need stenting when there are no good collaterals. And as I said, this kind of technique, finding the true lumen and placing a stent will resolve the dissection. Now, coming from acute stroke, coming to some complex aneurysms, which we are talking about, what we said was untreatable to treatable. So whatever newer techniques may be, still most of the patients we treat by classical balloon remodeling. That means a patient like this with a lobulated basilar top aneurysm, multiple lobules, you can in the whole of the basilar top, will inflate a balloon and place coils. But the key is to get a great packing. You shouldn't just place few coils and protect the patient because the aneurysm will recur. So this is what we have done. This is the balloon we are seeing, protecting the basilar bifurcation. And this is the end coiling. You can see we have coiled each and every lobule. And this is the end hole view, down the barrel view of both the posterior cerebral arteries. So arteries are preserved. So now we know in this view, these coils are not in the basilar bifurcation. This part of the aneurysm, which is anterior and posterior to the basilar bifurcation. So then we know this aneurysm may remain stable and patient likely to do well. Again, the challenge, as I mentioned, is to get a good packing in this brain aneurysm. So like just to depict you a case, ACOM aneurysm, 63-year-old with SAH, acute SAH, broad neck aneurysm. We talk about let's place stents, 1 stent, 2 stents. As I said, we'll do most of these cases with balloon. So this can see the anatomy, very broad neck. 3D is very useful to get the anatomy right. We place the balloon and we started coiling. But you can see the microcatheter is backed off. And you can see this part has got packed well, but this part is not packed up. And that's a usual problem in these cases, that all the compartments very well. So we reshaped, we gave a reverse shape to it. One curve like this, another curve like this, and made it pound into this part, which was not so well packed. And then we packed it off with this coils here. So we whole of this aneurysm, there's a blank roadmap showing where black is where all the newer coils are going. So when you know it's well packed, and in the end get a result like this, and this patient remains stable on, this is the 1-year follow-up, you can see stable aneurysm coiling. We use sometimes for very difficult bifurcation aneurysms. So what we do is we use 2 balloons. So like this patient with middle cerebral artery, ruptured aneurysm, you can see whole of the bifurcation is involved here, and multiple lobules again. This is the M2s coming from the aneurysm. So what we do is we create this kind of transparent view in which we get this endole, but on the barrel view of both the M2 origin. Now we know we have to save this area and coil all around, and this is how we do it. So we have placed two balloons here, one balloon, second balloon into the both the divisions, and third microcatheter for coiling. So of course one needs some experience and good imaging system and biplane system to do all of this. And then you see the first coil which we have played, compare this image with this one. So we have just spared this origin of M2s and coiled it all around. If you leave this part of the aneurysm will just come back and will never be safe. And once we have placed that coil, we pack all the area, the lower part and then the upper part separately. And in the end, you can see both the balloons inflated, and this is the coil mass. Now these coils are again not in the parent vessel. You know, these coils are in part of the aneurysm, which is involving this bifurcation. And in this view, you can see how this part was completely spared. This is the end result, and the follow-up as well remained quite stable. So the moral of the story is we have to secure the neck, and then a very good coiling in these aneurysms for us to be fair to the patient. It's just not enough to place few coils. If it needs one balloon, it needs two balloons, we have to do accordingly. What about when a branch vessel is coming from the aneurysm? It's a ruptured aneurysm. This is a middle cerebral artery bifurcation aneurysm. You can see this is the major division. There's some division coming from the aneurysm. And the next challenge is there are two lobules. So once you place a microcatheter in one lobule and get some coils here, it may be very difficult to enter this one. So again, you have to strategize to get hold of this aneurysm. And beforehand, it's not that during the case you try to change your strategy. Most of it can be done beforehand. So what we have done in this case, we have placed two microcatheters into the aneurysm, one here and one here. We shaped them differently so they enter different parts of the aneurysm. And then we have placed a balloon here in the main MCA and overinflated it. So when you overinflate it, bulge into the aneurysm, and it is overlapping this origin of this MC division, so that when you place the coils, the MC division here is spared. So this is known as balloon overinflation technique, as I talk about it. And once we had finished the coiling of the larger part through the second microcatheter, straight away we started coiling this smaller lobule, again the balloon overinflated, and in the end create a very dense mass of the whole aneurysm. And this is the end result. You can see this division is filling well, this is filling well, while the aneurysm is completely gone. And now maybe we have done a fair job. Even for very small aneurysm, we use balloon-assisted coiling, like this patient, young lady with SAH. This is a fenestration here, and you can see a small bleb. You know, this looks like a bindi actually, a small bleb here. But to me, this is not a blister. This is just a very small berry aneurysms which occur in these fenestrations anyway. So what we have done is we have placed the microcatheter right outside this small aneurysm. There's a very small 1.5 millimeter coil and balloon here holding the microcatheter. So the key is to coil from outside the aneurysm in this patient, showing the same thing that we have placed the coil here, and this is the end result. You can see it's very small coil we can do. So I don't like to place stent and flow diverter for these situations. Coming to flow diverter, so when do we like to place them? Now, all of us, you must have heard talks about flow diverters. So flow diverters, what they do is they're very fine mesh of wires. Once you place them, they reduce the flow, and then the aneurysm thrombosis, and then it gets fibrous and shrinks. And all this flow diverter is covered by intima, except for where there is a branch vessel arising, that remains as a whole. So we are truly endoluminally reconstructing that artery. Showing a typical case, this is a IC aneurysm with mass effect, partially thrombosed. You can see how the artery is buckled up here, and this is the DSA. So we have done some coils here, and then placed this flow diverter stent. This is the immediate. What you can see is that already there is some stasis coming into the aneurysm, but this is the follow-up. If I cut out this part, you can't say that there was any aneurysm. As you see, the whole artery angle has changed. It has remodeled. And the important point, the coils have come nearer to the vessel here. What it means is that the whole aneurysm has shrank as well in this patient. Now, what about complicated flow diverters? What about a patient like this? You know, this is a right ICA giant aneurysm, but you can see there is another small aneurysm here. There is another third aneurysm here. There's a fourth aneurysm here, and there is a fifth one here as well. So nowadays we are getting very long flow diverters, and what we decided, one, go to treat all of them by a single long flow diverter, but one can see it like this. And you can see the stasis in bigger one, this one already on the fluoroscopy images. And if you see the angiogram, most of them are already going or gone. And even the IC bifurcation is reduced in size. But if you see what we do in this patient is a CT scan right on the table. What you can see the diastasis in 1, 2, 3, 4, and 5, all 5 of them. So, so these are helping us to treat which were untreatable before. In posterior circulation, yes, also we use flow diverters that like this is a patient with a fusiform dissecting basilar aneurysm here and very difficult to treat. So what we have done is a one long flow diverter here. Now, what is this picture? It looks like a CT angio, but if you notice, you can trace each and every perforator here. How can we do that? Because this is something known as vaso-CT. That means we did intraarterial injection of dye, and during intraarterial injection, the C-arm of the DSL lab rotates and get a picture like this. This is 0.1 millimeter resolution as compared to 0.5 millimeter in patients in a regular CT angiogram. So we can trace each and every perforator. And it's very important to see this opposition. If you haven't got it right, if you got pockets left here, the pocket will thrombose along with those perforators, and then we will be in big time trouble. So that's very, very important part of it, that what we do is that we do a vaso-CT, check the position, and if need be, we always do balloon angioplasty in these patients. So this is the fall of this patient. The whole artery is remodeled and reconstructed. What about dissecting aneurysms with subarachnoid hemorrhage? Like this patient had subarachnoid hemorrhage, long segment basilar dissection. By the time patient came to us, it is growing like anything here, big lobule. This is the rupture spot. So, and both the vertebrals also look dissected. So what we did was we placed one long braided stent, which works like a flow diverter at times, and coiled it. And this is the follow-up. So even very long segment, we identify the rupture spot and we target the rupture spot and we treat it. And the artery can remodel and you can treat these untreatable patients. So when there are angulation, very long segment, then we use multiple overlapping stent. Like this is young man with a ruptured, acute rupture, middle cerebral artery dissecting aneurysms. And you can see multiple branches arising from it. So what we did was we placed one baby Leo stent, followed by a second one, and followed by a third one. And then we placed coils all around it. And this is the 1 year follow-up where it shows that it's a perfectly reconstructed artery. So you can sort of create a flow diverter by multiple overlapping stents to treat these ruptured aneurysms. What about dissecting very distal aneurysm? We like to occlude the parent vessel, but like this patient had an M3 MCA dissecting aneurysm. But when we did balloon test occlusion, this was motor cortex artery. You can see this is the artery, this is the MCA division. It goes here, takes the turn in the Silver fissure, then goes here. This is the aneurysm, this is the artery coming out of it, but this was the motor cortex artery. And balloon test occlusion did not show any collateral. So in the initial stage, we coiled it, partial coiling, but you can see the dissected narrowed artery. This is classical of it. And later on, because it was keep growing, we coiled it more and we placed a 1 micro stent there distal. We are in the M3 MCA at this point of time. And even in this millimeter vessel, we could place a stent. And this is the follow-up, which shows completely reconstructed artery and the aneurysm is completely gone now. And you can see how the whole artery has got remodeled and become straightened as well. There is one area where our group has really worked hard is the blister aneurysms. So if one message can go from this talk, if you see a picture, you can see broad-based hemispheric bulge in the supraclinoid ICA just before the bifurcation, and particularly points superiorly. This is not the location for any of these PCOM, choroidal, or ophthalmic aneurysms. So even if in CT angio you saw a very small bulge here, you know this is a blister aneurysms of the ICA. And in this kind of patient, it is very, very important to identify because there were high intraoperative rupture rates. So we don't treat them by flow diverters now. And I usually like to use single flow diverter, but what I do is I compact it here. That's the key to me. So what we do is we make sure the wall opposition is terrific and the flow diverter is very compacted here so that we get a lot of more flow area of the blister. And this is the follow-up angiogram, which shows completely reconstructed ICA. And this is what you can see in this image, this white line. This is the intima, which has grown over the stent and has completely healed. And our group has made multiple publications, and we are one of the first one to publish on safety of antiplatelet prasugrel loading. in these aneurysms and treating them with a pipeline device, which were published in British Journal of Radiology. And we have shown that when we load them 2 hours before and we go ahead with the procedure, we had a pretty low complication rate. But flow diverters work very well, stents work well for sidewall aneurysms. For bifurcation, a lot of newer devices are coming in as P-conus. You place it in the aneurysm, petals open up like this and you coil them. Or something known as Webb now has come, which is already available in our country. This is like an intra-aneurysmal flow diverter. So you place this device in the aneurysm, so you don't need long-term antiplatelet, and takes care of whole of the aneurysm. And this is another device which can place outside petals like this, and pulsar device, and then place coiling. So we had done one of the first web cases in our country, the official web cases under the supervision of Professor Jack Morey at RDMS, by showing one of the cases I proctored at another institution. This was a very broad neck basilar top aneurysm ruptured. So this is what we have done. We have taken a microcatheter here, and through that I'm releasing the web device. And this, when we are released it, we check by the angiogram that the PCs are spared. I can still take it out if I want to, if I don't like the position. This is the web device in the aneurysm. And then we detached it and we got an immediate complete occlusion in this patient. So this is really come in, is a very exciting device for the bifurcation aneurysms. So if I have to talk about aneurysms, of course, as mentioned, balloon remodeling remains the mainstay in ruptured aneurysms. But flow diverters are very useful for large giant IC aneurysms, and for even for blister small aneurysm, you can use flow diverter or stent assistance. Bifurcation, as I mentioned, balloon remodeling remains the same. Sometimes we use stents in those cases, and very selected cases, FD or multiple stents, but newer devices are coming in, and in future, their role may increase with time. What about AVMs? I will do very short thing on AVMs. AVM is truly a multimodality approach. Here I will not talk about through intervention, I'm treating untreatable. I think AVM has to be balanced between embolization, radiosurgery. Dr. Aditya Gupta, my colleague, is a very well-known radiosurgeon, and we have the latest CyberKnife and Artemis. He does it a lot. And a lot of times we operate upon these patients in our group. Most of these cases, nowadays, I like to use Onyx to take a detachable microcatheter and inject Onyx, which penetrates more of the AVM than glue any day. And it literally goes into the other arteries, and we detach the tip and take out the microcatheter. In selected fistulas, and when Onyx cannot be injected, then we do use glue. Just to show you a case, what's the principle? Again, it's not enough to just occlude the vessel. You have to penetrate whole of the AVM and beyond the AVM. What do you mean by beyond the AVM? This patient had a ruptured AVM bleed. This is the AVM. So what you can see, there is some bulge here, and maybe some bulge. You don't know what truly is the rupture spot. So what we do is vaso-CT in these patients. So this is the 3D, which shows that these are the two feeders. Now we can analyze the AVM in much more detail. And the vaso-CT shows, you can see this is the hematoma, the filling defect of hematoma, and the aneurysm which is bulging into there, and that's the key. Okay, that this is the rupture spot, and we have to target that rupture spot. So under the 3D guidance, we have taken a microcatheter here. We go deep into it. Once you reach the absolute nidus, this is the network which is filling. Then you penetrate the AVM. Now what important point is that we have penetrated whole of the AVM, and not only the AVM, we have penetrated as well. If I go back, you can see this network around it. So that means the AVM has got network around it, which we can't see. And penetrating that network is very, very important if you don't want bleeds or recurrences. So that's what I said. Even when DSA shows is gone, we keep injecting and we penetrate the adjacent arterial network, which we never saw on DSA, and the arrow showed it. And that's the key to get complete occlusion here, and which remains stable. So AVM, as I mentioned, multimodality. So that means this is a hematoma which needed surgery. So this is the angiogram, maybe this is the rupture spot. Direct surgery can be dangerous. So what we do with my colleague is we do one single session. That means in GA, we take it patient in DSA lab, we take the microcatheter, I embolize, it takes me an hour to do so. And this almost the AVM is completely gone now. And I don't change the last remaining bit, and straight away Dr. Aditya took to the operation theater, took out the hematoma as well as the AVM. So whenever we do preoperative embolization, we do it as a single session, which is much safer for the patient, much cheaper for the patient as well. And I think it's a great technique. And we like to use it more and more. Sometimes when it's large AVMs, what we do is we embolize them, like this large AVM which has ruptured. So we did embolization, and we leave a very small sectoral part of it. And then we know when Dr. Aditya feels he can take it up by radiosurgery, then we give CyberKnife to those patients, and this is the follow-up, the AVM disappears. So sometimes for large AVM, we reduce the size and do CyberKnife. Sometimes we embolize and do surgery, and sometimes we do embolization. What about newer techniques? In short, one is retrograde venous technique. Like this patient with the AV here, you see the occipital feeders, IC feeders, no good feeders, had bled twice. So how to go? There's a long draining vein which goes into the straight sinus set. So what we did was we placed a guiding into the straight sinus. We put the microcatheter into this. Yeah.
Fixate.
Just 1 second. I will unmute. I will mute everybody and then unmute you because several new people have joined in and there is a background noise coming.
Sure. Please go ahead.
Just give me 2 seconds, okay?
Sure. No issues.
Can you try speaking?
Yeah. Can you hear me?
Yeah, you're audible.
All right.
Yeah, you're audible.
So as I mentioned, in this case, we went through retrograde venous route. We took the guiding into the straight sinus, and this is the microcatheter being taken into this vein. And all through this tortuous vein, you can see we could navigate the microcatheter right into stem of the AVM. Once you're in the stem of the AVM, we injected honest, occluded the vein. Once the vein is gone, any further injection will keep penetrating retrogradely the AVM, including the feeders. Here you can see the mass later on retrogradely into the feeders as well, and we got a complete occlusion. So some cases when there are no good options of radiosurgery or surgery, and we think then we go through transvenous route and do this kind of procedures. Spinal AVMs is a big area. I'm not going to detail of it, but I will show you a massive AVM which would have thought previously untreatable. Like this patient had myelopathy, and this whole draining vein in this AVM is actually in the spinal canal. Feeders from costocervical, from vertebral, left vertebral, deep cervical, right vertebral. And you can see here the CT scan image, the sac is in the canal, which was causing compressive myelopathy. And this is the picture in the end. You can see massive AVM, in which clearly would have thought untreatable. So what the key in these cases is to going to the right side where the fistula is centering and just getting that part. So what we have done is known as pressure cooker technique. So we took a microcatheter here into that fistula and we placed this coil so that the material cannot come back. When it cannot come back, you don't want it to penetrate all the arteries. It's pretty useless. You have to get the fistula point. So when we inject, the material only went ahead, and you can see this. This is in the spinal canal. Here you can see in this picture, but you can see no feeders. Most of the AVM wasn't really injected, but we got the right spot where we're entering, and this is what it shows in the end, complete occlusion of the AVM. So by angio architecture analysis, and then using the right strategy, one can do this. Coming again to the ischemia, and last part of my talk about carotid artery stenosis and intracranial stenosis. So again, I mean, to us, it's a very, very standard and if I may say so, very easy technique to do. This is what the first thing we give to our youngsters to do in major neurointervention, carotid artery stenting. Done well is a very safe technique, less than 1% chance of major complication. So what are the indications? When non-invasive, symptomatic stenosis more than 70% in non-invasive, and catheter DSA shows more than 50%. Or asymptomatic, what they mention is more than 70% stenosis, and when the periprocedural complication risk to be low. But we are much more, let us say, tentative about treating asymptomatic only when it's more than 80 to 90%. And we do vasomotor reserve testing in brain in these patients, and we look at the age of these patients. Then only very few selected asymptomatic stenosis we would do. But the most important part is what we have learned overall in world literature is that the higher risk of stroke is in first few weeks in these patients. Patient with a DWI lesion like this and a stenosis is very high risk of stroke in the next coming weeks. And the revascularization should be done very soon. So usually within 3 to 5 days time, we go ahead and very next 2 days, this is the stent with the filter device and we'll recanalize this artery. We will not wait. So when would I wait? If patient like this CT angiogram showed a stenosis, but when we do DSA, you can see a filling defect here. Can you see the lumen, this plaque, and this is the filling defect. So there's clearly a fresh clot lying there. Whenever there's a fresh clot lying there, even if you do a filter device, there can be a risk of stroke. Then in these cases, there are two options. Number one, you go for endarterectomy. But if patient doesn't want to go for endarterectomy, then what we do is we put them on anticoagulant, usually Clexane, and for 2 weeks or so, along with aspirin. And that's usually the time, and what we can see the clot has cleared off the angiogram after 2 weeks, and then we go ahead with the stenting. And second category of patients, when there are big infarction, when we are worried about hyperperfusion, those are the patients when we would wait before doing stenting and wait for 2 weeks or more. The last part is intracranial atherosclerosis. I've been very passionate. I did my first stenting in All India Student Medical Science in 1999 or 2000. We used a balloon-mounted stent for ICAT or intracranial atherosclerotic disease. But it is very important. Around 25% of patients may have it. So one important point is you should get a CT angio, not CT angio, it is MR angio brain as well. Patient diagnosis. Second important point is the Sampras trial, which came that we said stenting was the greatest of options. But we have a lot of issues with Sampras trial. And I was in US at that point of time.
Whoever has joined right now, please.
Weave trial recently has come up, which is very important data. It shows that when you delay the procedure for a week after the stroke, then the complication rate is very low, only 2.6% or so. So that's the key. And I was doing that anyway. Why? Because most of these patients, when you do it in an acute stage, you could see overlying clots. The anatomy is never clear. So most of these patients, anyway, I like to wait for a week or so. So just to show you a case, this is a basilar artery stenosis. A young man, smoker, keep having TIA in spite of antiplatelet or anticoagulant. So we go in and we place a stent. You can use both balloon mounted or self-expanding, but I usually prefer self-expanding. I think they're very safe. When done well, this procedure to me has a very low complication rate on our hands. This is again the vaso-CT, recanalize artery. You not try to make it normal because then you'll close the perforators. And as I said, we used self-expanding stent in most of our patients' lives. Another patient, just to show you, ICA stenosis here, long segment irregular, again had repeated symptom instead of medical therapy. And as pointed out, we take the guiding catheter high up to get a very good control of the wire in this patient. Here you can see very irregular, severe stenosis here. So we tried angioplasty initially. Sometimes we just try angioplasty. If it works out, we leave it there. But what we could see post-angioplasty, there is a dissection flap here. So went ahead and placed a stent here. Again, a self-expanding stent. And in this case, it was Atlas. It's a modern self-expanding, partially open stent, very convenient to use. In this patient, this is what we did. And also now dedicated intracranial stents are also available in our country by Candice, and a good recanalization. So I would say, where are we standing in neurointervention? I will not take much time. We wanted to finish the talk so that we have got more time for discussion. That we have come to around 95% of patients we can treat aneurysm, we can treat it by endovascular means. AVMs, to me, your approach to be multimodal. Don't chase embolism. We don't chase embolization in this patient. Acute stroke, as I mentioned, is revolutionary change. And now we are talking about, we have already extended the window to 24 hours. We are talking about selected patients with large infarcts, selected patients you have to monitor very carefully who are a major vessel occlusion with low NHS. So all of that is coming in. We are trying to see how much more we can expand and benefit these patients. Carotid stenosis, as I mentioned, can be done very safely. We use a filter device and a very safe and easy technique. Intracranial atherosclerosis, selected patients we do take up for intervention, and usually when selected well has a pretty low complication rate. Thank you. Maybe I can just show a picture or two of ICA. Even an ICA like this, severe stenosis, slow flow ICA doesn't matter much. You can see slow flow artery. You go ahead, place a stent, and the artery opens up. And a lot of these, why I wanted to show this case was some of MR angio will show this as long segment stenosis because the dye doesn't go through. The arteries collapse because of low flow. Once you place a stent, the artery will keep expanding in these patients very well. I think we can just end here and go for question answers. Thank you.
Dr. Vipul, would you like to have questions right now, or do we have another talk?
No, I think that's all. Maybe I can show one or two cases of intracranial stenosis, and then we can just stop there.
Maybe I suggest that you go ahead, and then we'll take questions at the
end.
And
but just one or two more cases. Practically, I'm done. Patient with infarct, stenosis here. What I wanted to show the point was severe stenosis. Patient was again symptomatic. But this is the key. When you do a DSA, you see a severe stenosis. But what you can see within this red circle is clots. So a lot of these ICAT patients will have clot in acute stage. And that is where Sampras failed. You try to intervene, you'll cause embolism, you'll cause complication. Once they go up and cause infarction, that infarct will hemorrhage as well. So we do very careful angiogram. We see this clot, we waited in this patient, and the follow-up, the stenosis cleared up. And as mentioned, some of these patients will just do simple angioplasty. One small balloon, you don't want to make the lumen normal. You just want to open up to a degree where medical therapy can keep working. And this is what we did. The circulation improved in this patient. artery was just sufficiently opened up and then remained open on medical therapy. Again, this one of case of intracranial stenosis. What you can see is a severe MCS stenosis here. You take the guiding high up for safety, severe stenosis, cross it very carefully. Wire has to be kept in vision all the while by two operators, because that's a major chance of complication where the wire moves to and fro and ruptures this artery. And we place a self-expanding stent. The artery is well opened up. And what you can see suddenly from before, the circulation now has opened up tremendously. And that's another key, that you have to keep the BP down after that to prevent hyperperfusion breakthrough, and very strict control for next 1 or 2 days. We do transcranial Dopplers regularly in this patient to monitor cerebral hemodynamics, and that will prevent hyperperfusion breakthrough bleeding problem. I think this case we have already shown. I think we can stop here, Sumit, and we can go for question and answers.
Raj, can you please take up the questions, because I think it is more of your domain than mine.
So before I could go to the questions, I'd like to ask.
Just one sec. This is a housekeeping announcement. I'm unmuting everybody, but you please unmute only if you have to ask a question. Okay. So Zoom is going to ask you, that host is asking for you to unmute your microphones, but you unmute only if you have to ask a question, and then mute yourself again. Right. Muting everybody else.
I think
Please send your questions. Oh my God. Hello.
hello, yeah.
Dr. Raj?
Yes, I'm here. So
Yeah.
there are a few questions which are here. So I'm just going to read out those questions for you. So the first question is by Dr. Nishant Bhargava. So he has asked, what is your anticoagulation protocol in ICAP if you see a clot on angiogram? And
So, all right. So, you know what? For me, the convenient is that I've got this intervention neurologist as part of my team. So, Raj, would you like to answer this question? You know?
Yeah. Thank you, sir. So, I mean, as for the patients who have a carotid clot, and there is an ICS stenosis and a floating clot. So our protocol in the initial phase may be intravenous heparin infusion with monitoring of EPTT, maybe the first 48 hours or so. But beyond that, I think we can go for a low molecular weight heparin, maybe up to 10 days to 14 days is what we use. And by that time, usually we see the clot has dissolved and we go ahead with a dual antiplatelet after that. We use single antiplatelet and an anticoagulant.
Yes. So that's what I wanted to add on, that we give aspirin and anticoagulant, you know, in these patients. And then we just stop the Clexane 12 hours, 24 hours before, load them with Plavix. So I don't wait for 5 days usually in this patient. So I will give it for 2 weeks, aspirin and Clexane. Stop Clexane like on Saturday. On Sunday, load them with Plavix, 8 tablets. And then on Monday, we'll usually give aspirin 150 and 2 tablets of Plavix, and then do the procedure. So this is what we do. So just to add on, most of the antiplatelets nowadays have stopped waiting for 5 days. We just load them and do it the day before.
Yeah. So one main point Dr. Euclid mentioned is that clopidogrel takes at least 8 hours to kick in. So that is why we have to load the previous day at least. Otherwise, the effect of the drug is not there, and you risk the chance of stent thrombus and other things. So there's a question about so for tandem lesions, what is your approach? Whether to treat underlying stenosis first and then go distally for mechanical thrombectomy?
All right. So tandem is a whole talk. I mean, maybe we should organize a separate session. But So just for everybody's sake, what we mean by tandem is when there is an underlying IC origin stenosis and there is an intracranial IC or MC occlusion. So you have to go through the stenosis to do thrombectomy. So there's a controversy whether we should treat the stenosis first or do the thrombectomy first. And there are pros and cons of both. What we do nowadays is we do a small angioplasty, 2 or 3 millimeter balloon angioplasty. But when we do the angioplasty, the balloon getter is there and we do a suction, when we're deflating the balloon so that if there is any clot underlying there, it gets sucked out. We do a small angioplasty and then go across it, do the intracranial thrombectomy. And later on, we leave the wire across and keep checking on angiogram, how is it looking at? And if it remains fine, we don't do any stenting in acute stage. We are open to injecting a little bit of intravenous antiplatelet agent. And because most of these patients, they start forming clot on that stenosis. So we are okay with injecting a little bit of Riopro or any other antiplatelet agent and avoid a stent. But if we see that there are no good ACOM, PCOMs, and we see that infarct is not very big and artery started collapse, then we place a stent. But we try not to place them. Raj, you want to add anything here? Again, he has been reviewing a lot of tandems and,
Yes, I think so, sir. I mean, the other questions, many of them, if they have been thrombolized or not, is also a decision-making factor in such patients.
Yeah.
Thrombolysis, then almost certainly we would like to avoid a stent in that group of patients. But if there is a poor ACOM, PCOM, and if there is a large, deep infarct, then also those are the set of the patients where we may have to prevent stenting, because these are patients who can bleed into the deep core.
If I have to say so, somewhere we feel, I think Raj will agree, that we see a little bit more bleeds than what world literature would say. World literature, if you see, we have studied this topic in detail, it says no more chance or not more chance of bleed because of placing a stent. But in our experience, it's a little different. Am I saying so? I mean, Raj, would you agree?
I agree, sir. I mean, I think there is a bias in reporting. I think, and many of us as interventionists also remember our better cases rather than our problematic ones. So yes, we do see a lot more hemorrhages. In borderline course, we have seen reperfusion hemorrhages, and in the large deep course, we have seen reperfusion hemorrhages.
All right. So
that was a question from Sabarish Suresh, the last one.
Okay.
And the next question is from Gaurav Gangwani.
Okay.
He's asked again about ICAD. What is your preferred intracranial stent? Would you go for a Credo?
I think Tredo is a very good stent, no issues. And we have used before Credo was using Atlas. I didn't have any issues. Very easy stent to use. Atlas also.
And
only advantage of Credo may be. And what about? I just finished about Credo. Maybe that may be a better radial strength than Atlas, and you can deliver it through that same balloon which we used for Credo. So that is advantages that you use the balloon through the same balloon microcatheter, you can deliver this stent, so it avoids an extra exchange. While Atlas, if it is a very crooked artery, a lot of sharp curves, it sort of hugs the artery very, very well. But yes, in the current era, if I can do Credo, I will do Credo stent. But Atlas is also a good option. And
he has also moved on to ask, would you use coronary stents?
The biggest advantage of coronary are two. Number one, they're cheap. All right. And number two, they're drug-eluting. So for proximal stenosis, now in last couple of years, we have started using more coronaries than before. For proximal stenosis, particularly like vertebral V4 stenosis and I say cavernous stenosis, petrous stenosis, lateral segment stenosis, we have become much more open to coronary stenting, coronary balloons, and coronary stents than before. The problem is that in my hands, using self-expanding with very proper case selection has very low complication rate. So I'm not being too aggressive with balloon mounted because I don't know if I have a complication, I'll feel bad. I mean, they were doing well anyway, But yes, it's an option. Some people prefer to use balloon mounted stent all the way. So that's their choice.
So there's a question from South Africa.
Yeah.
It's on acute, it's on blister aneurysms. They ask, when would you consider a second FT and what is your protocol for follow-ups?
So that's very nice question because a lot of people in blister place overlapping devices and everything. While in blister aneurysms particularly, we have almost always used pipeline device. I've never placed second device, except for one patient when we use some other device, rebled, and we have to place another one. So we have placed pipeline devices, and I say we take a lot of care. We took 20 minutes maybe to deliver this stent in a simple anatomy because we want the perfect wall of position, good compaction at the site of the blister, and do the sizing very, very carefully. And thankfully, I mean, maybe I have experience, I don't know now, more than 25, 30 cases now. They do well. So as long as pipeline device is well deployed, well opposed, no issues, and we don't do early check angiogram any longer, I will do them at 3 months. Unless really there was a largest blister and I'm too worried, then I may do early angiogram in these patients. And only in one patient we didn't use a pipeline device, another device, and that patient had a re-rupture in 2 days, and we went ahead placed a second device. Otherwise, single device works. Now I've got 4 or 5 cases in which was a growing blister. That means I went as a proctor somewhere, and they'd done an angiogram a few days back. By the time I go there, aneurysm had increased in size, and even then placing a single device without coils in most of the blisters, it worked well. I think the key is the first procedure. But then if you have a doubt, then do an early angiogram, maybe at 3 weeks, 4 weeks, and go ahead with another device. Yeah.
I think the main question intent was to do you do early repeat angiograms?
No, we don't. Nowadays we do only at 3 months.
So the next question is from Manoj Bohra. In acute ischemic stroke presenting after 6 hours of onset, do you do perfusion studies in all cases or just a DWR?
Okay, that's a very nice question. Simply can be because that's very interesting. What imaging to do? So just for the benefit of everyone, less than 6 hours, technically CT and CTA are enough. As per the guidelines, when you go more than 6 hours is when you need some advanced imaging. It can be CT perfusion imaging, or it can be DWI plus minus MR perfusion. At this point of time, we are happy with DWI. In our center, some DWI gets done very fast. We have the same control room for CT and MR. So in our cases, we just do a quick DWI. If the infarct is small and the patient has significant deficit major vessel occlusion, we know we can offer procedure to that patient. Perfusion studies have become more controversial with time, and a lot of times is not really that strictly interpretable. So we are not doing it at this point of time.
And just to add to that, so there's just that the perfusion, the penumbra doesn't really determine your outcome. It's just the core that is going to determine your outcome.
Yeah.
So therefore, the core evaluation is the key, not the penumbral volume. Do you use Brilinta when you use stents? In case you require unplanned stentings as its onset. So if you have to use something stent urgently, what drug would you use?
So let me see. I hope you mean in ischemic. You mean, I mean, the key here is whether you're talking about ischemic or hemorrhagic. In hemorrhagic strokes, I mean, that means in SAH or whenever we want to place a stent, then we use Pastiburil or Brilinta nowadays because resistance level of Plavix are high. Unless until patient is old, more than 75, big infarctions or something, then we think this high risk, then only we use Plavix. When we come to ischemic stroke, even if I have to place a stent urgently, our group hasn't used Brilinta. We would usually give them high dose of heparin and aspirin, aspirin, and wait. If you have to go, we give injectable antiplatelet agents and let them convert to Plavix. For ischemic stroke, we avoid Brilinta unless and until patient has recurrent TIAs on Plavix. Those are the patients in which we have converted them to Brilinta. Yeah, Raj.
What is the line of management? This is from Dhruv Kapoor. Line of management in a patient with severe right ICA occlusion and left ICA 60% stenosis.
So it doesn't mention clinical. If patient, I'm assuming is coming in, you're mentioning patient has come now a cold stage. We're not talking about acute stroke. If the complete ICA is occluded past first 24 hours, when you're not talking about emergency thrombectomy stage and patient is stable, I would not treat incidental 60% in spite of 100% on the opposite side. 60%, it doesn't really change the hemodynamics a lot. 60% stenosis, still the flow will remain good. And I wouldn't do it. I will observe it very carefully. And it also depends on what do you mean by 60%. You have to realize CTA, MRA, Doppler, almost always overestimate. A lot of this 60%, when you do DSA, will turn out to be 50%. Even 60% DSA, incidental, I wouldn't do it. We'll just watch it medically.
So the next question is from Chirag. In acute ischemic stroke planned for MT, what is your protocol for bridging thrombolysis? I mean, do you give full dose or give a smaller dose for bridging? And there are a few questions following that, sir.
Yeah, Chirag, nice question. And since we have Raj Nivas as the thrombolysis expert in here, I will let him answer it.
Yeah, so there is
what is
as of
dose?
sorry, sir, what is
there a bridging dose? I'm asking.
No. So we see there are some studies which has compared 0.6 and 0.9 alteplase, but there is no difference in those studies, and they don't recommend that we use a lower dose for alteplase in bridging mechanical thrombectomy. So I would still go for a 0.9 milligram per kg dose followed by thrombectomy. There is no increased risk of SICH if that's what we want to know. We want to understand. Second thing is we may not bridge in certain specific circumstances where there is a borderline infarct core, where we feel that there is a higher risk of bleed, or where we feel that a stent may be required. Say, for example, if there is a tandem occlusion, then we may have to put in a stent. Those are the circumstances where we may not bridge a patient.
All right. So, and I think Chirag has added another question: protocol for anticoagulation, stent-assisted coiling in ruptured, or flow diverter, or any. All right. So, in these cases, what we do is we just load them 2 hours before the procedure, and usually aspirin or prasugrel, or sometimes Brilinta. Brilinta when the weight is less than 50 kilograms, or there's a previous history of TIA or small infarction, then we use Brilinta. Otherwise, in our group, we have been using prasugrel. So 2 hours means what? Practical means, it means when the patient being shifted from ICU, we just give them the medication. By the time they get shifted, anesthesia given, you are punctured, you are there, prepared to deliver this stent, usually it will be almost couple of hours. So that's our protocol. Anticoagulation, we just give them like 3,000 units of heparin. Only when we deliver the flow diverter, we give extra few thousands of heparin, and then nothing after the procedure. After the procedure, we just continue with the antiplatelet agents in these patients. And ICS stenosis in neck presented with stroke, would you go ahead with stenting in the same admission? So I will say something. So to me, it all depends upon what are the size of the infarcts. So usually acute stentings are the patient because small infarcts, and usually these patients are well preserved. Okay. This is a radiologist intervention way of looking at things. So I look at the infarct size and the ICS clean, then we can go ahead in the same admission. I think Raj will add here.
Just to add, only one thing is just a deep core. They are known to prone for reperfusion hemorrhages. So if there is a big basal ganglia infarct, then also just think twice about stenting.
Raj, you had reviewed literature.
Yes, So
which is the best time to do stenting? So he had written a paper on this.
Yes. So clearly, the first 2 days carries a higher risk. They say around 2.8% risk of a stroke. The third and fourth day, they would say around 2%. By fifth, sixth day, it drops down to less than a percentage. So I would say we wait for 4 days at least. And by fifth day, the risk significantly drops. So we normally wait for the fifth day or so to go ahead. I mean, that's the balance between the procedural risk as opposed to the natural risk. Now that medical therapy has improved, so they say you can potentially wait up to 4 days to go ahead with this.
I would just add here, to me, the increase in the stroke in the first few days is because there will be a clot sitting there. There is some small clot there. So even if you want to do it on a second day and there's a very small infarct, if an angiogram is clear, there's no doubt of any clot we look that for very, very carefully, then I guess it is safe. But as I said, as Raj mentioned, after 2 days, and of course the IC should be clean, the infarct should be small, then one can go ahead in the same session.
And the same thing, just filter use. There are a lot of studies which have said filters don't make a difference, but we feel that if you do stenting very early on, then the
Yeah,
macroembolism risk is high, and potentially it's better to use a filter in this set of patients because we are doing more stenting at the early stages.
yeah, that would be right. So the next question is, what's the best time for intervention management of patient with IC stenosis more than 60% and acute infarct? So as I mentioned, if the infarcts are very small, within first 3 to 5 days, very small dots, like the cases which I showed up. If the infarct is slightly larger, then we wait for 3 weeks and then do it. If there's a big infarction and patient has a big deficit, then we wait for 4 to 6 weeks. We also look whether the patient is improving or not. If the patient is completely hemiplegic, aphasic, what's the big point? Then you talk to the family. Then you do, and those are the cases when we'll wait for 4 to 6 weeks. But most of the patients with TIA, very small strokes, will do it early on.
Is CT angio as effective as CT perfusion imaging?
Sorry, I think the next question, Raj, was from Dr. Avinash. Dissecting the basilar artery when we place.
Oh, there's one before that. It's okay. So there's a question on CT angio. Is it as effective as CT perfusion imaging?
So that's a whole topic of imaging in acute stroke. The key thing is you have to see, as Raj mentioned, you have to see the core. That is number one. Number two, you have to see what works in your center. Until you've got a great system and you are a very good neuroradiologist, CT perfusion can have been, and you've got surface of CT perfusion, it is a problem. So I would say whether protocol of only CT, CTA, I'm talking about less than 6 hours, or CT, CTA plus DWI, or only MR, depends very locally, is the key. So less than 6 hours, if you don't have a great CT perfusion, just do with CT, CTA. If it is a big doubt and you get a very quick DWI, then do a DWI and let it be. As I said, we are not using CT perfusion any longer in a center, but what you can do is you can call me later on and we can talk more in detail, because it's a whole big topic and we can discuss what you have available in your center and what protocol to set in.
Basilar dissecting aneurysm, what is the risk of perforator infarct with FD?
So this question is very important one because it is known that there is more chance of ischemic complication with flow diverter in posterior circulation, and mostly because of perforator occlusion. So the way to avoid is that you have to have very, very careful placement of the flow diverter. You cannot leave gaps. As I mentioned, if you leave gaps, that is the area where thrombosis will form and perforators will go. That is number one. Number two is some people, what they do is they oversize the flow diverter. This is what we do. If I have to use a 3, I may use a 3.5 or really 4 borderline. When you oversize, the flow diversion effect decreases a bit, but probably risk of perforator occlusion also goes down. So selecting the cases very carefully. Once you have to do it, then you do it. And as I mentioned, number 2 is good opposition of a good stent. And number 3 is slightly oversizing it. And this is all you can do. But when you come to dissecting fusiform, complication remains high. That's the key important part.
Low NIHSS and LVO. What is your approach?
Great. So I showed this case, but I didn't go into much detail because I thought we'd finish the talk, have more of discussion. So this question is important because, as I mentioned, a lot of patients with major vessel occlusions, and they will come in when they're clinically intact or not a major deficit. But I didn't quote with a paper published in AGNR some time back, which showed around, and that study, they put the patient in 2 groups into medical management versus immediate thrombectomy. And they found that half the medical management group patient needed an emergency thrombectomy. So that we mean, when you observe, maybe 40 to 50% of these patients will deteriorate because their collaterals, they're surviving on collaterals and collaterals fail after a while. What do we do? In Indian circumstances, we tell about this to patients. Since our patients are self-paying, a lot of patients, they opt for medical management. But in these patients, then we observe them very carefully, we consult the family, and we are very, very closely monitoring them in ICU for any early sign of deterioration so that we don't waste time for thrombectomy if we have to do so. In Western world, they go ahead with thrombectomy. It's the insurance issue and patients' compliance is much better. I mean, they can go ahead with that. Yeah. And double balloon technique for coiling. Do we give additional heparin? increase BP, and how long do you keep the BP? Yeah, that is important, because when you place 3 microcatheters, the chances of thromboembolism are higher. So in these cases, as long as we have got the catheters in, we'll keep a higher heparin than maybe other ruptured cases. The key thing is, as soon as you get the first coil in or 2 coils in, and that's the time we have to keep increasing the heparinization level. Most of the complications of aneurysms in our hand are ischemic, not hemorrhagic, and that is true world over. So one has to be more liberal with heparin in these patients. Increase the BP. I don't think I actively increase the BP, but just tell them to keep them well hydrated and keep the BP to the normal pre-op level. In every aneurysm patient, we tell the anesthetist, let the BP be normal pre-induction level. In our center, we don't increase the BP, some centers do. And how long do you keep the balloon inflated? I mean, there is no sort of perfect science to it, but we are okay with 4 or 5 minutes. We are usually all right. What you have to realize, when you're occluding the artery, whether you use single balloon or 2 balloon, you're occluding the main MC or the main A1 anyway, so by and large, it doesn't make a change. The chance of embolism are more multiple devices. So you increase the heparin and you keep checking the ACT, and in the end, we'll take the ACT to 300 or so. And after the procedure, you keep watching the angiogram for next 20 to 25 minutes. That's very important, because at that time, you may see some clot formation, and one can give injectable antiplatelet agents very safely. So you don't see any increased thromboembolic rate.
People, can I ask a question?
Please, pleasure.
Distal protection devices.
Yeah.
Do you routinely use them for carotid stenting, or it is an optional device?
Okay, so Sumit, again, very important and can be a controversial question. So let me see what I'm doing. I'm doing for most of my cases, 95% cases I use it. If I feel beyond the stenosis, there's a very tight kink in the artery and stenosis is a very smooth one, symptom happens some time back, then rather than struggling with it, I think it is pretty safe. It's a safer option just to do without a filter. Or if it's an incidental smooth stenosis, then the plaque is not a ruptured one, and you think placing a filter is a hassle in that anatomical issue in the patient, one can do it without a filter. I will be okay with it. Most of the difference comes in very irregular, dirty, acute plaques, probably. In our center, we watch the filter device, maybe in 1% or so, or 1.5 to 2%, we see some embolus there. Most of these patients will do well without a filter. Maybe change it, makes it 1% safer. But as I said, we place it in most cases, but I think it's a challenge. Then I'm okay with avoiding it in selected patients.
Thank you. Actually, I asked it for more for the population who was attending the meeting rather than myself.
Yeah, I know that. Yeah. All right, Raj, what's the next one? I mean,
what is the window period protocols for posterior circulation stroke?
Raj, I mean, again, would you like to answer? I mean, here.
So rather than a time window, we go based on tissue windows. So, there is a scoring system for the posterior circulation on DWI. So they say that you score each level, you give 4 points, like the mid-brain, pons, and the medulla, depending upon the extent of involvement. So if there is more than 3 points, the outcome is going to be poor. But more than 5 points, then the patient is not going to do well. Say, for example, at one level, at the midbrain level, both sides, the median and lateral half are involved, then the patient is not going to do well. So those are patients where you have to clearly explain to the family that despite thrombectomy, this patient may be in a persistent vegetative state. So I think it is tissue-based rather than time-based.
All right. And Raj, so there is a question, we can discuss this from Dr. Moaz. Difficult thrombectomy cases, how many attempts before amending? And do you employ Y-stent thrombectomy for difficult thrombectomy cases? So,
I mean, it's a whole talk which you have planned for the next week.
what I would say is next week, it's on 1st May, we have formed an international panel of foremost authorities on this issue of when to fail, when to stop, what to do, when to expect a failure. So I would say, please do attend that. I think, I missed it. Maybe I should have just put up a slide there in the end talking about it, but we'll try to get it across in all the forums. As I said, Dr. Ron Noguera to me is one of the best person to talk on this issue. Best talks I've heard from him on this issue. So please do attend next week. That one will be very, very fruitful and focused on ischemic stroke and particularly on these kind of issues which you mentioned. So maybe, but in very short, usually will take 3 to 5 tries. You have to realize once you fail, after third, fourth, fifth never really works. That's the bottom line. It gets worse and worse. In our center, we haven't done Y thrombectomy. We'll rather shift to Solomra technique or something else. Rather we haven't done Y. Maybe it is useful. Maybe we have got financial issues in India. But Professor Rene Chapeau and many other authorities have shown why stenting in these patients. So we haven't done it, but yes, it's an option. So that's in short, but next week we'll discuss this in detail. And window period is done. Do you prefer aspiration first, hybrid technique, balloon guiding, or not? Now, again, it's like a controversial question in between our department as well. I think most patients, they do very, very well with balloon guiding and stent retriever. Clearly, the evidence is coming in when you do balloon guiding, distal aspiration catheter and stent retriever, probably that has the best outcomes, okay, if you ask me, all right? Because of finance issues, so we first go as balloon guiding and we just try to take out with the stent retriever, which works well in majority. The key in that is we always use long stents, all right, 4 centimeter. That is number one. Number two, you deploy the stents much further away from the clot so as to trap it. And what we do is we push and fluff technique. That means once you initially deploy the stent, you keep pushing it out. All of these are huge help in getting a good, doing a good thrombectomy. In selected patients, when there is an ICL loop or tortuosity, and where there are two good ACOMs, PCOMs, and we are worried about balloon guiding working out, we straight away start with a Solumra technique. Aspiration technique, my colleagues are more fond of it than me. It also works. When it works beautifully. Posterior circulation is one place where we do, because it's difficult to place balloon guiding into vertebral arteries. We are very okay with using aspiration as a first choice in posterior circulation. And as I mentioned, what they mention as trap technique or a complete technique, balloon guiding, distal aspiration, as well as stent retriever. At this point of time, world literature, that is coming out to be probably the most effective technique, but you have to balance with your financials. Yeah. Small vessels, Raj, maybe you can ask this. Small vessel stroke presented as wake-up stroke. Will you directly go for DWF here or CT brain with angiogram? What would you do?
So although clinically we can reliably differentiate small vessel from a large vessel, in 10% of patients with small vessel, there could still be a large vessel occlusion. So I would definitely do a vascular imaging if you have access to it. Of course, if you want to confirm, then you'll have to do a DWI, because these can be very small infarcts that can be easily missed on a CT if the patient presents early.
All right. On an average, how much is the cost of simple mechanical thrombectomy stent assisted in your hospital? It is variable. Why I'm saying variable? Because we are very ready of letting go of our fees in these patients. We are very ready to get the material free done in these patients to make it happen. I hate it. A patient wants to get it done and just because of some lack of money, they don't get it done. Okay, so we may quote 3 lakhs for the procedure. All right. But as I said, I'm very, very clear to me is variable. We try all the way to make it happen at whatever cost. Unless the family is not keen, then you can't help it. I hate that patient doesn't get it done. If they have 1.5, we will not say you have to deposit 3 to do it. We'll just go ahead and do it. So we tailor it to the patient, very frankly. So we have even kept one stent retriever, new one separate, extra in our department. So in emergency, we just use it and we don't bill it to the patient. We have kept one device like that, which is available for us for free so that we can make it happen in our unit, and cost should not be a major issue. Yeah.
In eye care, other instances, you go directly for stenting or only when double antiplatelet treatment fails?
Okay, so to me, Sempristyle was a flaw. I was in US, they were too aggressive, those guys, they messed it up. I think selected patient is a pretty safe procedure. So technically, we always go when there is a double failure, then we recommend very strongly. But if I see a very severe MCS stenosis, classical atherosclerotic, clean stenosis, hypoperfusion in the MCA territory, then I tell them I say Sembriz has failed, but in our hands, this is a safe procedure. And we give them the option that we can wait on medical therapy or we go ahead with it. That means in very severe hemodynamically significant stenosis, clean stenosis, focal tight stenosis, I do give them the option between medical as well as stenting, because I feel it can be done safely in those patients. But most of these patients, which we do 80 to 90% are when they fail on medical therapy.
Symptomatic extracranial stenosis, up to what window do you operate on them? Beyond which window do you feel there is no benefit of giving stenting after?
Raj is perfect. Again, he has written papers on this. And it's not something which is nice for us interventionists to hear, that our stenting will not work, but he will tell you beyond what window the benefit really drops. Yeah, Raj.
See, actually, it depends upon the extent of stenosis. If it is between 50 and 70% stenosis, then there is no benefit beyond 2 weeks. If it is between 70 and 99%, they say up to 3 months. Beyond 3 months, it virtually behaves like an asymptomatic stenosis. So that is the.
I don't really believe this, I don't like it. But these are the facts. And as interventional neurologists, neurosurgeons, we should be aware. The key thing is that let us do it early on.
Yes, yes.
And even when they enters the asymptomatic category, if there's a severe stenosis which has been symptomatic in the past, I will still like to do it because the complication rate also is very low in this patient.
Yes,
1%, less than 1%. But yes, technically, by literature, as Raj has clearly answered, the risk of stroke really drops with time. Okay. Raj, question. How do you assess NHSS in posterior circulation stroke when patient alters sensorium? Well, I will answer it in very short. Raj assesses.
I also don't assess. We take for thrombectomy because these are patients where you can't really assess. These are very high NHSS patients. So
usually very high NHSS patients. That's what Raj means to say. If they are clinically well preserved and major vessels are not blocked off, then But most of the posterior circulation, there is no confusion.
Raj, may I ask something?
Yes, sir.
What is the maximum number in one particular component of NIHS which you would give, and what would be that component?
Sir, posterior circulation, I would give the maximum number, that is 42.
So that's what I'm saying. There are several segments in NIHS.
Yes, yes.
So which segment has got the maximum numbers?
Meaning in terms of a particular say like if the power is 0, then it goes to a 4, sir. That is the maximum number I would give for a particular model.
What would be the sensorium?
Sorry, sir?
Sensorium, level of sensorium.
Level of sensorium, it goes up to 6, sorry. Nowadays I would actually...
That's what I wanted to highlight.
Yes.
That the importance is that if a patient is in altered sensorium, then the NIHS is already crossing the level. I'm not a stroke, so I'll allow my...
Well, to me, as an interventionist discussion between neurologist and neurologist, we interventionists don't get it. Come on.
Yeah, so please carry on. Sorry to interrupt.
No, that's all right. Where are we?
ICAT cases, symptomatic, NHSS. Any role of thrombolysis in MRI negative stroke, Raj?
Yeah. So MRI may not be positive. So just, for example, a patient 80-year-old had some vision disturbance and presented within half an hour. So we had thrombolized. So initial MRI can still be negative. There are good collaterals. So if clinically it is a stroke, even DWI negative, and you should go ahead with thrombolysis. MRI need not necessarily be positive.
So my add-on, thrombolysis is extremely safe as well in these patients. So
yes.
Yeah.
And particularly posterior circulation, unless sometimes you have to do, they do axial cuts and they may be 5mm cuts, and you can easily miss a small DWI lesion. Sometimes we do a coronal cut so that to see if in a different plane we could pick up these DWI. So we should thrombolyze.
Dr. Gaurav, can we have session for clinical evaluation of stroke patients? Well, Raj can do it for you guys. Propose it in some forum so we know number of people are attending, at least some, maybe it can be 10 people. and he takes these talks actually, how to identify major vessel occlusion clinically. And I think Raj has some videos as well of that. So definitely, so why don't you contact him directly or me directly? If you don't have his number, I'll give you his number, and I'm sure he'll be very happy to organize it.
Sure.
So post-medical thrombectomy, how much is the maintenance BP? If when patient is awake or under GA, as much perfusion bleed can occur when patient wakes up. So again, I think Raj is better placed.
So it depends upon whether we were able to open up the artery or not. If we have been able to open up the artery and completely reperfuse, then we can definitely reduce the blood pressure. Particularly if there is, so what we do is we do an expert CT post-thrombectomy, and we look for any enhancement or if there is any bleed in the infarct core. So if any of these features of avid enhancement is there or you suspect bleed, we aggressively reduce the blood pressure. I would at least drop the systolic by 20% of the pre-existing blood pressure. In fact, we also get a repeat CT scan done within a few hours to see what's happening to that. Is there an increase in the bleed or not? If the patient has received thrombolysis prior to the thrombectomy, and these are the cases where we anticipate potentially a bleed can occur and expand also, then we may have to plan our treatment as per the clinical situation demands.
But of course, I may add, any patient of intervention, when you're extubating is the key, BP rise should not happen. So we really work actively with our neuroanesthetists. We've got a dedicated neuroanesthesia team, and they know about this. So we actively work with them that maybe they have to extubate them low or whatever, but they have to control the pressure. Any neurointervention patient, that's a very critical period when you are extubating the patient and major cause of trouble. And as I mentioned, but most of these patients nowadays we do under local anesthesia.
And most reperfusion bleeds tend to occur in the basal ganglia, and they tend to predict poor prognosis as well, as opposed to cortical infarcts. So you see a large basal ganglia infarct as opposed to another patient with a big cortical infarct. The basal ganglia infarcts are the ones which are likely to bleed. So in these patients, you can be much more aggressive in controlling the blood pressure, provided you've been able to open up the artery. If you have not been able to open the artery, then you'll have to keep the pressure slightly higher up so that the collaterals work in that set of patients.
Okay, last question. At least what I can see is for thrombolysis, is there any experience of tenecteplase in your center? So Raj, I mean,
so now we have not used tenecteplase on a regular basis, but the NORTEST trial didn't show, it was done to prove superiority, but unfortunately they couldn't prove that. And therefore you cannot say it is non-inferior to alteplase. And the current guidelines in the ASA, AHA is that it's used only for minor strokes. However, the Indian trial shows some benefit. Benefit with tenecteplase is as good as alteplase at 0.2 milligram. But what I would suggest is if you're planning to use tenecteplase, use 0.25 milligram per kg, which is the dose that has been universally recognized now.
Raj, can I ask a question?
Raj, I'm just going for 30 seconds. My laptop is low on charge. I'm just getting
sure.
So you guys keep discussing.
Raj, can I ask a question in between?
Yes, sir. Yes, sir. Please, sir. Go ahead, sir.
What are the negative points with tenecteplase?
There are no negative points, I would say. In fact, there are. The molecule is technically superior to alteplase because it's highly fibrin specific, and the defibrinogenemia which we see with alteplase is much lower. In fact, you don't get as much defibrinogenemia as with alteplase. The second thing, it's a bolus dose. And the last thing I would say, we cannot decide it based on cost. So, but on merit wise, the molecule technically is only thing they claim is it is not the trials that were done overseas were with metallized, and the tenecteplase that which is available is it's not a biosimilar molecule. So that is the claim from the company itself.
Okay, so do you feel that a bolus dose is in any way a negative impact on the molecule? Because you cannot, sort of titrate it.
So most bleeds occur with alteplase at 6 to 8 hours after the entire infusion is gone. So we don't really see bleeds in the first hour. And that one of the reasons I think is the fibrinogen level goes to its lowest at 6 to 8 hours from the initiation of the TPA. However,
So why
tenecteplase.
people is not around?
I'm coming.
So
Are you back?
Yeah,
he's
I'm coming. I'm there.
Yeah. So while sorry.
Yeah.
So suppose you have given a patient any thrombolytic agent,
Yes, sir.
and during the episode of transfusion or infusion, you find that the patient has developed, say, a headache or a worsening of his symptoms, then you would obviously go in for a CT scan or imaging to see if there is a bleed.
Yes.
So if there is a bleed, what would you do for that time?
Okay, the first step is to, of course, if he is on alteplase infusion, you stop the alteplase. Then I would, the second thing is, I would definitely reduce the blood pressure. One of the proven factors to prevent bleed expansion, say what we know for sure is 1/3 of these bleeds would increase by 1/3 of the volume in the next few hours. So the first step is stop the drug and reduce the blood pressure by at least 20%, 15 to 20% of the systolic. Now, next comes the question of whether we give in these patients cryoprecipitate or not. So there is a varied sort of literature on that. One of the suggestions they say is to do fibrinogen levels and fibrinogen FDP, fibrin degradation products. If the fibrinogen level is less than 150, it is worthwhile giving cryoprecipitate for this particular patient. And the dose is, we have to use at least give 10 cryoprecipitates to increase it by 70 milligram per deciliter. So these are the steps I would use. Some people also give tranexamic acid. I think it is reasonable if the bleed occurs at the time of infusion. For example, if the bleed occurs 6 to 8 hours later, at that time, I don't think tranexamic acid works. However, if it is happening right at the time of infusion or just immediately after that, then I would give tranexamic acid as well.
Again, at the cost of repetition, this question was not for me. It was basically for the public who's attending this.
Sure, sir, sure.
Yeah, please carry on with your discussion.
How do you differentiate between reperfusion bleed or contrast leak on express CT?
Would you like to answer this?
Yeah, so sometimes it can be quite challenging to differentiate in the initial CT. So quite often what we do is we early repeat CT. Blood will remain for a while, but whereas a contrast will wash away and the CT, the hyperdensity will start going down. But to be one of the other ways is to probably do an MRI, SWI, if you're really worried of a bleed, to see if there is any blooming. There's another option is this to do a CT at two different energy levels. And you can create what is called as an iodine map and a contrast map. And that is something which is coming up now. So because MRI, again, the patient, you will have to get an MR done. But now there's a way, this is called as a dual energy CT. You do one CT at a particular voltage level. You repeat the CT with another voltage level. And you do these maps where you can have contrast plus iodine map and one map which is an iodine map alone, that is the dye. And then you can subtract and see if there is actual bleed or not there in that particular CT.
I think next question, Dr. Moaz, on dry thrombectomy. Can you just again type the question? I don't understand. Raj, do you get it? What is dry thrombectomy for in-house strokes? So, Dr. Moaz, can you just write in a little bit detail what exactly you mean by that? Then maybe we can answer this question.
Or no IV TPA, so direct thrombectomy.
Oh, okay. All right, got it. So, I mean, okay, so we have reviewed this literature. So there are many advantages or disadvantages when we say whether we give IV TPA, if you can do direct thrombectomy or not in these patients. The advantages giving IV TPA is that some clots will lyse. So you're delaying at least half an hour, 1 hour, maybe, you don't know, by thrombectomy, trying to do thrombectomy directly. When there's a partial flow, then that those clot lies up pretty well. One of the advantages supposedly of TPA is when we do a thrombectomy, it takes less passes. Or maybe when there's a small distal clot, they get lysed by the IVTP. In return thrombectomy, there's a distal clot, you can let the IVTP work. The disadvantages of giving IVTP, number one is cost. Number two is that you should not delay the treatment. It doesn't cause more bleeds for sure. I mean, this is what literature shows, that there is no chance of more hemorrhages because you're given IVTPA. Now, what you have mentioned is clot fragmentation. So many interventions mention this point. Some of these cases from a ICF block or M1 block, it becomes a distal MCF block, but the clot has lysed and gone up, and they say it becomes more difficult for thrombectomy. Coming around all these factors, the ultimate answer is that some studies have shown there is no difference, and some studies have shown there is some advantage of IVTPA. So in our center, I don't know, Raj may say differently, but we would give IVTPA when it can be given. We don't change our protocol a lot. There are many randomized trials going on this issue, and we will know better in future. Raj, you want to add on?
Yeah. So one of the things in hospital strokes, one of the things you may have to keep in mind is they may be unwell patients admitted for some other reasons. So these are patients you have to look out for like an alternate cause for a stroke also. Like say patients with we have seen one patient with an infective endocarditis. So we'll have to be careful about the red flags for these particular patients. Some patients may have low platelet counts. These are the two things which we have found which may cause an issue. But otherwise, yes, we can we bridge these patients also.
So Raj, question to you. Minor stroke from Dr. Asir. Minor stroke NHS 1 to 2 with minor infarct. In window wasn't thrombolized, but after 2 to 3 hours become worsened, should we thrombolize?
See, this will be out of the guidelines, but we
Raj,
have.
He says 2 to 3 hours, so that is whether you're still in.
Okay. So if you're still in the window period, I think you should go ahead and thrombolize. There's no doubt in that. But there are some patients who will deteriorate maybe 6 hours, 7 hours, and there's a very small infarct core. Then it's a difficult one to answer, because we have thrombolized patients maybe day one they had presented, and 3-4 days later we had thrombolized again. Unlike previous thrombolytics where antibodies can form, here we don't have the issue of antibody formation and lack of effectivity.
Raj, they're not thrombolized in first go. He just deteriorated after 2 to 3 hours.
Yes. So we should thrombolize if it is in the 4.5 hour window period.
What about 5.5 hours? What will you do?
So at that time, I would repeat an MRI. If there is no big infarct core, then potentially one can consider. However, all these hemorrhages are time-based. So if you see the trials that have been done up to 9 hours, there are higher risk of hemorrhages, symptomatic intracranial hemorrhages. However, the wake-up study that had come recently, they say that in this 4.5 to 9 hours, if there's a very small core, you can potentially consider, but that is beyond guidelines as of now.
Yeah, and I would add on here, if you think, of course, mechanical thrombectomy role comes in there, and some of these patients, they have small vessel occlusion. One may think about low-dose intracranial TPA. Even if there's no major vessel, you can't do stent retriever. A patient has significant deficit and motor cortex artery is involved, then we may think about at 5-6 hours doing a low-dose TPA. And so what are the doses mentioned for TPA, intracranial TPA in these patients, Raj? I mean, is there any more data?
So the doses that have been used is around 0.3 milligram per kg. And we know that it is 0.9 milligram per kg for the intravenous use. But intraarterial, it is 0.3 milligram per kg. But most trials, they've used just 0.1 or 0.2 milligram per kg for distal small clots.
Yeah. After using Webb, do we use antiplatelet as part of it? Is in the true lumen? Well, technically, 99% of Webb is in the aneurysm. And only the detachment zone that is projecting into the true lumen, but it supposedly almost never causes embolism. So only patient where one would use antiplatelet on a long-term basis if If during detachment, after detachment, part of the web has encroached upon the parent vessel, the web has bulged into the parent vessel, that's the case one would use antiplatelets. But for the detachment zone itself, one doesn't use. Regarding antiplatelet resistance, what is your protocol? So for hemorrhagic stroke, intracranial stenting or flow diverters is very simple. We don't use Plavix at all nowadays. We use Prasugrel or Ticagrelor, which don't have resistance. So after that, it has been a boon. We don't see that kind of thrombus formation or issues which you used to see with Plavix. Unless and until, as I mentioned, patient has largish infarct, very old, we think it's a high risk to give Ticagrelor or Prasugrel, then only we give Plavix for intracranial aneurysm stenting or flow diverter placement. When it's come to ischemic patients, at the moment, we don't have Verify now in our country. You can do antiplatelet resistance testing beforehand by thromboelastography. I tried it, but I don't really think it's really reliable. We have stopped using it. So we use Plavix in these patients, but we watch them for half an hour, 40 minutes after the procedure. If there is thrombus formation, usually I would convert to Plavix BD. But if it's too much thrombus very early on, then I may change to Ticagrelor. Or in spite of Plavix BD, after a few days, they have again TI or something, then we change to Ticagrelor in the ischemic patients, whether it's carotid artery stenosis or intracranial stenosis patients. We still use Plavix as a routine. But we watch the patient after the procedure for half an hour, 40 minutes very carefully. I think, is that it, or we have more questions? Sumit, Raj?
I think that is also. That is all.
Great. I think, you know what, as I mentioned to everybody, we have planned a very exhaustive session with, as I said, one of the best authorities in the world on ischemic stroke intervention. Dr. Ron Noguera is part of that panel, which is there next week. So anybody interested in ischemic stroke and all the issues and thrombectomy issues should join us next 1st of May. We'll be sending the details shortly. I think it's evening time, 7 or 7:30, right?
It's 7 p.m. sir.
7 p.m. Indian time. So that's very
1st of May.
Yeah, 1st of May. So Chirag, thanks a lot. Thanks for participating. Chirag, great to see people known to us, and Nishant and Moaz, it's my mistake. I forgot to press recording. I mean, I've been telling everybody to record everything and everybody, but you know, like a good senior, I blame Dr. Rashnivas for not reminding me. So maybe I will just record this talk any other time and upload it. All right, I will do that. It's my mistake. Yeah. Yeah, it's my bad. I know. Thanks all, Vineet. Good to see you there. Great. Love
Sir,
to.
can I just one thing? Can we just share my screen just to show the invite, or you just?
Please share the screen. Good. That will be great. Yeah.
Yeah.
We have still got around 80 people there. So
let me see if it is there. So this is what, as sir has mentioned, like we have tried to address the difficult problems that we face during thrombectomy. So we have this challenge to reperfuse. Many times we do feel that, and it may be just the clot is the problem, or the artery is a problem, or maybe the drug or the technique. And there are three experts. One is Urs Fischer. He was a past Secretary General of the ESO, and he's the chair of the Stroke Center at Bern. And Raul Nogueira, as Dr. Ruples mentioned, he is the past SNVI president. Again, he is a very excellent speaker, and he particularly goes into the problems behind what is the reasons behind the problem. And the third speaker is Mikhail Mazigi, and these last two of them are interventional neurologists. So, and he's also a prolific writer. Both of them are well written quite a lot of research articles relevant to failure to reperfuse.
So see you next week then. Yeah. I can see a recording button on. Is Sumit recorded?
Yeah, it is recorded already.
Oh, you recorded it. Sumit, you're gone. We can't hear you anymore.
Sorry, guys. So we have all recorded it. So anybody who's interested in getting a recording of this event should send a SMS to Dr. Vipul Gupta or Dr. Raj Srinivas directly.
Otherwise, we'll load it on the YouTube channel. We have got a Stroke and Neurovascular Foundation, and we'll just load it on their YouTube channel, Stroke and Neurovascular Foundation. If you go, we'll just
so
load
that
it.
is one aspect. And if not possible, then you can SMS to Dr. Vipul and Dr. Raj directly. So they'll be more than happy. And I still have not got any response from Dr. Subhash Kaul.
Yeah, I was seeing him. I could see, sir. And I thought whether, sir.
Are you around?
Yeah. Hello.
Hello, sir. Good afternoon, sir.
Good afternoon.
Good afternoon.
I think it was a great session. It was a great session. I really enjoyed.
Pleasure, sir.
So we have something honor to have you there. Next week, sir.
Yeah.
So,
and I'll be more than happy if you could be Vipul and Raj, with your permission. Can we make it the chairperson?
Yes.
For that?
But yeah, pehli baat meri permission nahi. I'm not involved in that. Thrombolysis is you guys. and please don't do this to me.
Let us make Dr. Subhash Kaul as the chairperson so we can ensure that he's going to be around.
Absolutely.
No. That will be a pleasure. I really didn't have. I learned a lot.
I was going to propose it, Sumit, and you said it before me.
Yeah.
Thank
you.
Let's make Dr. Subhash Kaul as the chairperson. I will be a silent moderator.
But let me congratulate your team. It was just world class. I just enjoyed it. It was like a song for me. So perfect.
Is the
Fantastic.
pleasure